Uh, my background is actually in public health and specifically in global women's health before coming to VCU. And in coming to VCU, I've been getting a lot more experience with women's health psych and substance use, and I've been working with the Ivy Lab for the past 2 years now, which is crazy. Time goes by very fast. So I've been working with Dr. Martin on a couple of studies, but currently I'm the research coordinator for the SORT study. And SORT stands for Sleep and Opioid Use Disorder Recovery and Treatment. So it's a mixed method study, meaning that it's both survey and qualitative interview data that investigates sleep and OUD treatment and recovery. And that study is where today's presentation comes from. So today's presentation is patient-reported preferences for sleep interventions among a population of women with opioid use disorder. So I do want to start the background by talking about insomnia generally before getting more specific about insomnia in our population of interest. So insomnia is defined as difficulty initiating or maintaining sleep, and its prevalence in the general population kind of ranges, but I saw anywhere from 5 to 20%, so chronic insomnia up to 20%. So to qualify for an actual diagnosis of chronic insomnia, someone has to have been experiencing it for at least 3 months or longer, and acute insomnia is when it's less than 3 months. The implication, like the public health implications of insomnia, are actually a very big public health importance. So the insomnia is associated with daytime fatigue, a whole host of negative mental health outcomes, including depression and suicidality, functioning impairment, reduced quality of life, and increased healthcare costs due to such sleeplessness. Insomnia is super widespread, but also kind of nebulous. There's a lot of causes and contributing factors that do cause and maintain insomnia. So there's genetic predisposition, there's comorbid psychiatric and medical conditions, chronic pain is a really big one, but also maladaptive thoughts, so like negative cognitions relating to sleep. So insomnia can really just span a whole gamut of just causes and factors. So although a lot of attention has, I want to transition a little bit to talk about insomnia in MOUD samples, and that's medication for opioid use disorder. So a lot of attention has been paid attention to sleep in the process of active substance use to early recovery, because that's a time of a lot of sleep changes. But sleep disturbance does persist into OUD treatment and recovery. So when I was doing like a very rudimentary lit search for this, there's a lot of literature about interventions with successful treatment entry in this time period, the period from active addiction into early recovery, but not much once in long-term treatment. There's not a lot of literature about that specifically. But after initiation of MOUD, sleep problems can persist for months and even years. It doesn't necessarily go away. A really interesting systematic review of sleep disturbance in MOUD samples indicates a really wide range of documented prevalence, but from 19 to 41%, which is much higher seemingly than that of the general population. So this is really important to look at, especially knowing that MOUD is a long-term treatment intervention, if not lifelong. So research indicates that sleep disturbance may negatively impact OUD treatment outcomes. So interventions that address sleep disturbance is a potential avenue to address treatment retention once stabilized on MOUD. So now I want to shift focus a little to how this might impact our population of interest, which is women with OUD, who might experience unique challenges with sleep. We know that specifically sleep disorders are more prevalent among females than males. And a lot of factors can underlie this sleep disparity, including roles of sex-specific hormones, to more kind of gendered social determinants of health factors like women are more likely to be caregivers, live with children and family, and other things that can impact sleep. Dr. Martin presented about this, so I shamelessly took this graph from one of her presentations, but I think it does a really nice job at highlighting the fact that insomnia, OUD, and gender and other social determinants of health kind of play into this complicated relationship where none of them necessarily lead to the other, but they have their unique, like, two-way street kind of relationship that shape each other. And that's really important to look at all these factors in relation to one another. So treating insomnia among women on MOUD patients might be an effective route to improve OUD treatment and recovery outcomes. But the effectiveness and the acceptability of insomnia treatments and MOUD treatment is unknown. So we know a lot about insomnia treatments and how they work in other populations, but not this population necessarily. So having this information can help inform and develop tailored interventions to address such insomnia. So the objectives for this study that I will be presenting about are to explore past experiences and beliefs about sleep, medication, and therapy for sleep, and investigate patient preferences and acceptability of sleep interventions, including medication and therapy among women with OUD. So I will be submitting this as an abstract for the College of Problems on Drug Dependence conference. The conference is in June, so I'm really looking forward to your feedback about the overall presentation. I have some follow-up questions at the end, but I look forward to hearing people's thoughts. So this is a secondary analysis of survey and qualitative interview data of women in outpatient OUD treatment. Participants are recruited from the Motivate Clinic. So that's where I'm the research coordinator, and I know several of the medical students on the call are involved with that. So the inclusion criteria for the survey are non-pregnant females, or at least 6 weeks postpartum, receiving buprenorphine for OUD for at least 6 weeks. And it's important to note that they had to be non-pregnant or at least 6 weeks postpartum, because pregnancy can kind of add a confounding factor to sleep, and it's hard to extract what sleep problems could be pregnancy related versus other factors. So that is kind of an important reason for why they're excluded. And for the inclusion criteria for the interview component of the study, so once people are enrolled into the study and complete the surveys, as part of the surveys, they complete something called the Insomnia Severity Index, or the ISI. So if they reached a score of 10 or above on the ISI, that indicates clinically significant insomnia, and we invited them to participate in an interview. So the ISI has a range of 0 to 21, higher scores indicating higher levels of sleep disturbance. And so the interviews were semi-structured interviews, meaning we had an interview guide, and they were based off of conceptual domains from the socio-ecological model of sleep health. So these interviews were about 30 to 45 minutes. They were mostly remote on Zoom, conducted by me and the prior research coordinator, Stephanie Violante, with someone else from the study team on the call to take notes. Questions were asked as is from the interview guide, with follow-up questions asked for clarification if necessary. So kind of the analysis. So for the quantitative element, just descriptive statistics. For the qualitative, we're utilizing applied thematic analysis, which from my burgeoning understanding of qualitative analysis is a way of saying identifying themes from the data after it's been collected. And the SORT students have been very helpful with this process. Future analyses will include frequency counts of these themes using in vivo, which is a qualitative analysis software. And we are currently in the process of analysis of these themes now. So now to talk about a little bit about the results. So 11 people have completed the qualitative interview. So I'll talk a little bit about them. So as you can see, of the 11 participants who participated in the interview, they were predominantly white, with a mean age of 35. And they are also primarily unemployed and unmarried. And so we do ask about if they're currently using medication for sleep or currently receiving therapy for sleep. So there's kind of low rates of current therapy for sleep. A higher proportion were using medication, almost about half the sample, but only a few of them were receiving therapy specifically to address sleep. So only 2 of the 11. So these are the 7 items for the insomnia severity index. So as I shared, the participants did have to get a score of at least 10 on this to qualify for the qualitative interview. So the numbers are a little high, the rates are a little high, but as you can see, a large proportion endorsed difficulty falling and staying asleep, as well as problems with waking up too early. They also reported being dissatisfied with their current sleep pattern. And all of the participants reported that their sleep problems were at least somewhat noticeable to others and at least somewhat worried about their sleep problems. And finally, about 3/4 of the sample reported that their sleep problems interfere with their daily functioning. And so in the surveys, we also do ask about preferences for sleep interventions. We kind of go more in depth with the qualitative, but in the quantitative surveys, we do ask about interest in medication and counseling and coaching. So all of them would use a medication that was safe to take with their buprenorphine, and almost all of them would utilize a counseling or online coaching option if it was available through the current OUD treatment program. So now on to talk about the qualitative findings, and this is really interesting. So I will be presenting kind of each of the themes as well as the summarized codes within the theme. And then for the sake of brevity and time, I picked one code with a quote to highlight it, and that is what is italicized. So theme 1, prior experiences with sleep medication. So we found that the sample had a lot of experiences with medication for sleep. Some of these medications worked, some didn't necessarily work to improve their sleep, and some of the medications worked but had undesirable side effects. So women would be like, yeah, this medication helped me with my sleep, but I felt really groggy in the morning, or it gave me GI side effects, so I didn't want to continue to take it. And so that is the medications that have impacted sleep. And then we also found that medication and sleep treatments for this population were kind of siloed. So people would take medication, and probably medication more often, and do therapy, but not necessarily both at the same time. So this quote from one of our participants: "I feel like I've just never taken the time to really focus on sleep. I've just fixed it with a pill." And I'm not blaming the doctors, and I'm not saying they're just throwing medication at it, but when they're seeing 5,000 patients a week, what more do they have to offer when they see you once every 6 months to a year? I feel like if you took therapy and sleep therapy and medication together, it would probably really work. So demonstrating a lot of interest in having kind of both the medication and therapy component, which typically operate separately. So then the second theme was preferences for medications to improve sleep while in recovery. So people wanted the medication to have the ability to improve sleep quality and quantity, i.e. they wanted to sleep better and longer. They also wanted it to help with their mood, such as irritability, as lack of sleep would affect their mood negatively. So they wanted medication to help with that. A big one was that they wanted minimal sedation effects. So almost all, if not all, of the sample of these 11 participants were parents and or caregivers. So they wanted the ability to sleep without being sedated, or as they would often put it, knocked out. So they would say, and this is a quote from a participant, I would be willing to try a sleep medication because I would definitely like to be sleeping better. It depends on what it is, because I still have to be able to wake up if my daughter is crying or if something happens. And then finally, within this theme, it was important that there was not a risk of developing a dependence on the medication. There's some really interesting quotes to highlight this, but participants expressed, of course, that they had negative experiences in the past with developing dependence. And so they didn't want to have that experience with sleep medication, particularly as it relates to their recovery. The recovery is very important to them, and they didn't want a medication to compromise that. So then the third theme, with challenges to employing non-pharmacological strategies for sleep while in recovery. So abstaining from substances that interfere with sleep, it was challenging, a sample would say. So particularly caffeine and nicotine. Almost universally, the participants expressed that giving up on cigarettes, tobacco cigarettes specifically, would be really challenging. And I know Catherine is on this call, who's a med student doing some interesting analysis on nicotine use in this population. But anecdotally, I think almost all of these participants, these 11 participants, smoked tobacco. And we know that nicotine makes it harder to fall asleep, but a lot of people do depend on that kind of pre-bed cigarette. So when presented with a list of kind of the most challenging strategies to employ, giving up nicotine was really one of the highest. Also, mental health symptoms can oppose the implementation of some of these non-pharmacologic strategies for sleep. So a lot of participants expressed anxiety or recalling traumatic experiences from when they're in active addiction. So noted that a lot of the strategies for sleep around cognitive restructuring or addressing thoughts would be hard. So cognitive restructuring is a kind of jargony term just referring to when you have a negative thought, kind of shifting it, reframing it, replacing it with a counter statement or a more positive thought. And that's a challenging thing to do when you're having mental health symptoms. So an interesting concept that I wanted to highlight, so when I'm talking to the participants about things that would keep them awake, I was newly introduced to this concept of stinking thinking, which is a term that a lot of participants learned while they were in rehab, which refers to what we psychologists call cognitive distortion. So thoughts about how you're not good enough or you'll fail at recovery. And these don't have any evidence, right? But they're persistent. And so these thoughts would just be challenging to cognitively restructure. And then finally, current physical environment would render non-pharmacologic strategies hard to implement. I see that it's cut off a little bit at the bottom, but a quote to highlight this is, reducing time spent awake in bed would be challenging. Just because my room is the only place that I've got that is like quiet and away from everybody else. Because there's 12 people in the house, like 8 kids and 4 adults. And so of course that sleep hygiene strategy that we suggest of only use your bed for sleep, don't be in bed if you're not using it for sleep. That would be a challenging thing if you have that lack of physical space. And so then finally, the fourth theme, so preferences for therapy intended to address sleep for individuals in OUD treatment. So almost all of the participants, when asked about the benefits of telehealth, expressed the convenience of telehealth options and being able to do chat sessions from their home. Participants also really highlighted the need for flexibility of in-person session durations and formats to accommodate their competing schedules and responsibilities. This is a population that has a lot of responsibilities and obligations to others and people to take care of. Another thing for preference was in-person options to promote treatment accountability. So a quote to highlight this. So in-person therapy holds yourself accountable to be 100% honest and open on what's really going on. There's a lot that you can tell from a person. I speak with my hands, my facial expressions, how I'm carrying myself. So going in person would probably make me feel a lot more believable to the process than just being told over the phone and over video, hey, do this and tell me how it goes. So you can see there's kind of some mixed feelings here, but I think what both the preference for the in-person options and the convenience of telehealth options really speaks to the second code here, this need for flexibility in being able to do one or the other. And then finally, within this theme, ongoing social determinants are barriers to in-person sessions. So again, just those challenges with ongoing things happening in these participants' life, which would make it challenging for them to regularly attend in-person sessions. So some of the take-home points. So among women receiving buprenorphine, this qualitative research demonstrated the complex socio-ecological factors that affect sleep. And so we kind of need this evidence-based tailored therapy that accounts for the unique social determinants of health that affect this population. And within that, in collecting more information about this, we found that therapy and medication were broadly acceptable. And medication especially might be desirable, but really considering past experiences with taking medication, particularly as it relates to recovery, and that definitely has an impact. So that is my presentation. I would love to get some feedback about the overall presentation. And then maybe we can have a little bit of that discussion. And then I do want to get some feedback about specific measures to use. So yeah, I would love to hear everyone's thoughts.
Great job, Michelle. That was awesome. I love how you summarized the findings so far. And everything you said, just write all that down, then you can just write it up and publish it, because it was great. It was wonderful to see this study kind of see the conclusions that we got. And it just makes sense, right? Especially for those of us who treat patients, and also those of us maybe don't treat patients, but have been doing the study, right? And talking with patients about sleep a lot, because I know they anecdotally was like, oh yeah, my sleep's really bad. Let me tell you more about it, even though they were just completing a survey. So I thought that was wonderful. So I obviously have seen this presentation before, so I'm going to open it up to other people who have some feedback for Michelle on things that they really thought were really pertinent, and we can take those to note, because those are things we can really highlight in the discussion of the paper and for this abstract for the conference presentation, or other points of clarity, things that we should clarify a little bit more.
I have a question. Did you have any breastfeeding women in the study, or women who were pumping and then feeding the milk to their babies? Because breastfeeding could impact like how often they're waking up, and then also if they are feeding breast milk to their child, it could affect like what kind of medications they would feel comfortable taking to treat sleep.
That is such a good question, because so they had to be at least 6 weeks postpartum. We do collect information about like whether they're currently breastfeeding in the surveys and the kind of family history survey, but we do ask specific qualitative questions about like what was pregnancy and postpartum like for your sleep, and a couple of times breastfeeding would come up and the kind of challenging schedules that like breastfeeding really demands. So it's not in this presentation, but we did collect that data, and breastfeeding was certainly one of the barriers to sleep that they mentioned in that part of the interview.
Great job. I had a question. You talked about some of the challenges, kind of the realistic part of it, like, not having another room to go to, or wanting to make sure that you can hear your baby cry, those kinds of things. Have you thought about recommendations for clinicians when they're dealing with patients on how to subvert some of these challenges that patients have expressed?
That is also a really great question, and something that I also deal with a clinician a lot. I am a therapist and I work in a primary care setting, and a lot of the therapeutic interventions for sleep is a lot of like psychoeducation about sleep hygiene, and then asking them to kind of see how it goes, try these things and see how it goes. And it's just challenging because when you introduce these things around sleep hygiene, like reducing the time spent in bed, just not using nicotine, like all of these other things, those are really challenging to do, and also wrapped up in a whole host of other things, right? With smoking, you would have to do smoking cessation. With reducing time awake in bed, there's like a housing, social determinants of health component. So there's something really interdisciplinary there, and it's hard like in the therapy setting to know specifically what to recommend. I think it's about working within the resources that they do have available and kind of continually working session over session to see what is amenable to implement, what is not necessarily as like able to implement, and recognizing that there are just going to be significant barriers to address and kind of working with them on addressing them. That was kind of a long-winded response, but yeah, did I answer your question?
Yeah, thank you. Actually, I have one more if that's okay. This is just like personal curiosity from my research interest, but how is from the clinician side, like reimbursement and payment for sleep disturbances for the clinician? Like, is there a mechanism in which you can get paid for rendering the services that are obviously take a while? Like any kind of education is going to take more time, but is it like a viable solution from a clinician level?
That is a good, yeah, Dr.
That's
Martin.
That's a good question. And yeah, because I don't know, Hannah, if there's like, so from a billing and coding perspective, like I document insomnia as another chronic medical problem that needs medication management. And so I can upgrade my level of an E&M, like my visit, my outpatient visit, to a higher level when I have a certain number of chronic medical conditions, and insomnia counts as one of those. Now, is there like an extra bonus I can get, right, for, you know, sleep hygiene or something along those lines, like I do for smoking cessation? Like smoking cessation, there's an extra CPT code, so I can bill for smoking cessation on top of my outpatient visit if I document all the things that billing and coding wants me to do. I actually don't know that. That's a really good question, because when we're doing that, if we can get paid for it, that would be wonderful. But we do document at least an ICD-10 code for insomnia. And then if it's in part of our management, we can, you know, it does inform the level of the outpatient visit.
Thanks, that's helpful. I know that like clinicians obviously do a lot more than that they can bill for, but it's helpful to know like what specific services like smoking cessation that you can actually bill for, and then obviously from the research perspective, what would show up within claims data.
I can tell you that if there is some magical extra code that I could be doing to get extra, you know, reimbursement for sleep hygiene education, I'm not doing it. So from a claims data research perspective, like you're interested in, Hannah, if there is such a code, I don't know how reliable it would be, because as a clinician, I don't use that. I don't document to that code. Like I do for smoking cessation, I do document, so I can do that code.
Hey, Dr. Martin.
Thank you.
So I think there's like a Z code for it. Like if you look up ICD-10, there is, but yeah, just from my residency experience.
Great discussion. Any other questions? These are all really great.
Hi, I have a question and I hope it makes sense. I'm just wondering, so you mentioned that there are previous studies with people who are transitioning from the active addiction to like starting recovery, and this study, I assume it's like people who are taking medications. And so do you see like the patterns between the two groups? Are they like similar, like the findings that you get with?
Yeah, that's a really good question. And I might toss this to Dr. Martin, but I just know that in doing a literature search, like the process, like sleeping when you're in active addiction is really varied. And so then when you're going through the process of, you know, recovery and withdrawing from substances, like sleep is heavily impacted by that. So it becomes really, really challenging. And so then in early recovery, it shifts a little bit more, but it's still like a really jarring process to the body. So sleep is definitely impacted. And so the idea is that like in long-term recovery, like, you they've been on MOUD for a while, so maybe their sleep has stabilized or improved, but we're learning that sleep disturbance can still very much last into long-term recovery and into MOUD treatment for a while. So, but I don't know about what the literature says specifically about the differences specifically in sleep from those two kind of phases. I don't know, Dr. Martin, if you want to chime in.
Yeah, there's some like data on it, but it's like a little bit scattered. So I don't really have like a great theme to it. And it's like and then the problem is that they all use these different clinical samples. Like some start buprenorphine, some start methadone, some people are detoxing, some people are doing buprenorphine tapers. It's kind of all over the place. And so like there's a couple of review papers I've read and I'm like, oh, great. They're going to tell me exactly what you just asked. Like, how does the data change or the findings change between these different stages? But I read it and I'm like, I don't really use this. It just doesn't seem like useful information to me because it's not consistent. The samples are all so different. And especially because, unfortunately, even though like a lot of our research in the lab is focused on patients who are in opioid use disorder treatments, because that is what I'm interested in and that's what we focus on because it's important. Unfortunately, not everyone with opioid use disorder who gets treatment gets medication for OUD. Like the majority of people don't. And so like Hannah and I were just in a meeting this morning looking at Virginia Medicaid data, and I don't remember, it was like less than 40% of people in the sample that we looked at, initiated medication for opioid use disorder who had an opioid use disorder diagnosis in our state, at least within this Medicaid sample. And so it's hard because then the samples that end up being in these studies are representative of the real world, right? But from a biological perspective, right, of what medications do, and from like a clinical perspective, like a patient on medication is going to have a very different treatment plan than a patient off medication. It's just really hard to synthesize that data right now. So I'm not trying to say that in the discussion of Michelle's paper, she's going to have to correlate our findings with prior research, like that's what you do in a paper. However, we're kind of starting a little de novo because there's very few studies that have focused on this specific and have been very clear about their sample. Like we are focusing just on people who are stabilized on medication, identify as being in recovery, and kind of just being like, other studies have been done and they've been a little bit mixed. We're just kind of starting off fresh because I can't really compare our study to others because it's all so heterogeneous, unfortunately.
Thank you.
Yeah.
Hey, Michelle, I think you did such a good job on your presentation. I think you did a good job of emphasizing how impactful sleep is in OUD treatment, because I know there's a lot of factors that really impact treatment outcomes, like mental health, socioeconomic factors, and I didn't really realize how important like sleep was and how like intertwined it was in treatment outcomes. And you did a really good job of emphasizing that in your presentation. And I had a question about the MOUD itself. Like, how does buprenorphine affect sleep? Like, I know some people like feel sedated when they're taking buprenorphine, or do you know if it like causes insomnia, like in the long run, like maybe the MOUD itself has an impact too?
That's a really good question. And the first part of this interview really gets at how we asked them, like, how does buprenorphine affect your sleep? And they shared some really interesting responses. So I'm not sure about like what's going on specifically, like neurocognitively when you take buprenorphine in sleep, but what our participants shared kind of varied. So some would be like, buprenorphine really gives me energy. I need to take it in the morning because it gives me energy throughout the day. And some participants said that it made them sleepy. So they would take it at night when they didn't want to feel sleepy during the day. And they also really kind of tied the buprenorphine to their sleep schedules too. So kind of using when they took buprenorphine out like throughout the day to align with their sleep schedules. So it definitely varied, which was really interesting to see.
Yeah, that's really interesting. Yeah, I know that happens with a lot of medicine, like it affects people differently. So they take it sometimes in the morning or at night. So yeah, thank you.
Great discussion. Thank you, everyone, for your questions. Any others before I then attempt to farm everyone for some ideas on some of these quantitative measures? Okay. So we are, as part of the manuscript, hoping to use it's mixed methods, right? So we're hoping to have the qualitative data, but then find some quantitative data to complement it. So here is the list of surveys that we collect as part of SORT. So they are varied, but they kind of go, they're in different categories. So there's some about like social determinants of health. There are some measures about substance use history, withdrawals, and cravings. There's some about sleep, beliefs and attitudes about sleep and current sleep behaviors. There's also quality of life, so the quality of life overall scale and the promise. There are some mental health measures, so the trauma and PTSD, PCL5, the PHQ-9. And then this last bucket is kind of the neurocognitive measures. So I guess if you think about what I presented qualitatively, what from these quantitative measures would you be interested in knowing more about?
Think of those on the right, that important ones for sleep would be like the trauma and PTSD, anxiety, maybe the Edinburgh postpartum screening as well. Things like specific to this population that can really impact sleep.
That's a really great suggestion, especially from the qualitative data. You know, some of the participants reported that a lot of their traumatic memories from when they were in active addiction really impacted their sleep, and that would be a really big challenge to try to address. So kind of looking at that in the trauma and PTSD measure would be really interesting. Thanks for that suggestion.
A lot of people started their substance use because of trauma, or, you know, to cope with the physical effects of that trauma, and nightmares is a huge trigger for a lot of people.
Yeah. That's a great point. I see that AB mentioned in the chat, sleep beliefs and attitudes measure. Yes, that is something that we definitely want to look at. I forget the exact questions with the beliefs and attitudes about sleep, but the higher you score on the measure, like the more dysfunctional beliefs and attitudes that you might have about sleep. So it does give a kind of sum, but within it, there's a lot of interesting just questions and beliefs that they might have. And so that would be interesting to look at, especially with the qualitative data where we qualitatively got some of this information, but being able to quantify that would be a nice complement. Anything else? Well, that was very helpful. Thank you, everyone. I really appreciate your participation and your feedback, and it's really exciting to see this data come to life and be able to share it. So I'm very appreciative. Thank you.
Yes, thank you, everyone. We've been trying to rack our brains about some of these things, so your feedback was really helpful. Great job, Michelle. It was amazing to see kind of everything come together. And it's very clear that you know this data inside and out, which is obvious with all the work that you do with the study, and also leading the great team that we have working on the SORT study, which many of them are on this call too. Any last feedback or questions or comments that people have for Michelle or otherwise? Okay, well, if not, thank you everyone for coming to our last Ivy Lab meeting of the calendar year in 2022. We will be back in 2023. We will let you know when, with some more presentations and updates from the lab, and hopefully some good, fun, exciting announcements too. And thank you again for all the feedback that we got. And thank you to Michelle and Lilia. And we will see everyone soon. Have a great winter break. Bye. Thank you.